Sir, Experience Center for Advanced Research and Excellence in Autism and Development Disorders, head. So this is about sir. Sir, over to you, sir.
Thank you, Mr. Viraswamy, and thank you.
Yes, sir. Thank you, sir.
Yeah. So let me just, I need to share my screen, I think, 1 second.
Yes, sir. Yes, sir. Please, sir.
Yeah. Yeah, hi. Yeah, I presume at least half of the people gathered here are postgraduates, or maybe more than that. And it's joy to address new young doctors and maybe have an opportunity to learn from them. Yeah, like introduced, I'm Ashok. I work at St. John's. I've been there for very many years. Okay, and while my core area of interest is to child psychiatry and autism in particular, we've worked on depression in slightly earlier years. We have developed a depression identification instrument for use in India, but it's going through a lot of modifications. And right now we are also developing an anxiety disorder related tool under the ICMR task force. So yeah, there has been some interest, and we have recently we're trying to kind of fine tune an adolescent depression scale that's just waiting for some confirmatory factor analysis, but otherwise a lot of work has already been done. So there's been some work in the area of depression, and like I will say later, we also had some connect with depression and diabetes and so on. So some amount of background in that, but more than anything, an opportunity to talk to postgraduates, it's always welcome. And I'm extremely sorry that this program had to happen last Saturday, and I had simply overlooked the fact there was a national IPS meeting. I don't know how I overlooked it, but it was a big error on my part. So thank you all for all those who have actually managed to join us again this evening. Okay, I'll try and share screen. Hope you can see this. Can you see my screen? I'll make it slideshow.
No, sir. Not able to share, sir.
Correct. I'll not wait. Hang on, I'll just do the share screen part. I don't know if I need to be given some permission.
Yeah. 1 minute, sir. Yeah.
Yes. Yeah, shall I? Now,
yes, sir. Yes, sir. No, yeah, you can share, sir. Yes, sir.
So has it kind of come there? Can you see my screen? Or?
1 minute, sir. You please share the screen, sir. Not able to see, sir.
It says it's a sharing screen.
It's only black color only coming, sir.
Okay. Where's the next step? Have you stopped sharing, Mr. Viraswamy?
No, now you are sharing, sir. Now we are seeing your, sir.
Can you see it?
Yeah. Now we are seeing, sir.
You can see it's not
visible, sir.
Slideshow. I'll put it now in the slideshow mode.
Yeah,
and you can
yes.
Sure. Okay, there we go. All right,
sir. Thank you.
Yeah. So last 1 year, all of us are learning to teach postgraduates virtually. It has its share of fun, challenges, intrigue, sometimes not knowing who is behind that name, and sometimes there are people, 2-3 of them sitting behind one name. Yeah, it's I gather this meeting is to address postgraduates, and hopefully we can share some views and learn from each other. And there are a couple of new antidepressants which come as part of the presentation, and I hope you will all teach me more about that, because I'm not really that well informed on that. So let's start. And the interesting topic is not antidepressants, mind you, it's about treating depression in the 21st century. So we'll keep that in mind, and hopefully our discussions and questions will be around that more than getting caught on any single specific antidepressant. So the scope for today's lecture, broad scoping of depression. It's an endemic issue in 21st century. It's all over the place, everywhere it's seen. And what are our efforts to formally address it? Okay, of course, on the request of the organizers, they will focus on 2 new molecules and an old established molecule. And I must say, I'm grateful thanks to the organizers for some of the resources they have allowed me to use, which they have prepared. And of course, I want the last section, and I really want some interaction there. And I hope to run through the slides quickly so that we can finish by 8:45. Hopefully, there are many slides actually. But if we finish, then we'll leave some 15-20 minutes for good discussion. Random musings on how the societal approach to managing sadness might look like. Okay, so now depression as a pathological entity. Let's just quickly have a look at what ICD-11 and DSM-5 says. And there are also growing evidence to say it's probably not just in the brain, but it's probably caused by some kind of physiological disturbance all over the body, some kind of a desired homeostasis which human beings have learned to kind of see it as a value, somehow gets shaken up by some physiological perturbations. That's one growing view of depression. So we'll talk about both these things. Yeah. Right. One very good resource, and since this is for postgraduates, I thought you should all know this. I've actually quoted from this study in the next few slides, especially the section by Mario Mas, who has actually worked on the section on depression in this article. So, mental behavior neurodevelopmental disorders in ICD-11, an international perspective on key changes and controversies. If by any chance you all have not seen this article, it's freely available. Please go there and get this article, read it. It's going to be something very useful for you. I'm going to give you just one more resource. This is World Psychiatry 2019. Again, free access, innovation, and it's got some incredible impact factor. It's a very special journal, but it's free access. And it's the Journal of the World Psychiatric Association. Innovations and changes in ICD-11, classification of mental, behavioral, and development disorders, Jeffrey Emery. And there are about 30 authors there, including Shekhar Saxena. It will be nice for you all to read this. Between the two, you'll get a sense about how depression is going to be conceptualized in about a couple of, maybe by next year when ICD-11 actually starts getting officially recognized by everybody. Now in ICD-11, I'm going to go through this a little bit because we're going to talk about treating depression in the 21st century. So we need to have some idea, and this is going to be probably running for another 30 years. So I think it's good to have a sense about how official systems look at depression. So mood disorders are divided into depression and bipolar disorders broadly. Depression may be a single episode, recurrent, even dysthymic, and mixed anxiety depressive states. Simple classification: ICD-9 depression was coming in some 20 places, ICD-10 it was coming in countless number of places. But here they're making it pretty simple. And there is the separate section on persistent mood disorder like dysthymia, all that has been removed, but dysthymia does get a mention. And but most important, mind you, there is a section called prolonged grief disorder, which is more than 6. No, it's not 6 months; it's actually more than 6 months, and that is something very specific to ICD-11. In ICD-11, a depressive episode is defined by the concurrent presence of at least 5 out of 10 symptoms, same as DSM-5, which must occur most of the time. And one of these must be depressed mood or marked diminished interest or pleasure activities. Can I ask any one of the postgraduates, do you find any key symptom missing here? Any of the postgraduates, can you please tell me if you think from what you're used to from ICD-10, any major symptom missing here? Concurrent presence of 5 out of 10. Okay, one of this must be depressed mood or markedly diminished interest or pleasure. That's anhedonia. So depressed mood, anhedonia, find that some of you might have guessed, is fatigue as a symptom. In one of the major symptoms is missing. It's made one of the 10 symptoms. It can still get counted, but it's not made as a prominent symptom on par with depressed mood and anhedonia. Okay, and it should result in functional impairment and etc. So here, depressed mood, marked interest, and then a whole lot of cognitive kind of features, one related to concentration, and then a lot of thoughts about helplessness, hopelessness, worthlessness, suicide intent, and so on. And then vegetative symptoms like sleep or excessive sleep, weight loss, psychomotor agitation or retardation, reduced energy or fatigue. Fatigue comes there, but it's not given the same prominence as depressed mood and anhedonia. So the list includes one important symptom. You'll be surprised, DSM-5 does not seriously focus on hopelessness. Hopelessness is seen as something very integral to depression by ICD-11, and in fact, they feel that this alone can actually count for a lot of other symptoms when they do field studies. Okay, and they do talk about how depression separates from normality and normal grief, and this is very important for you all because the whole topic is about treating depression in the 21st century. And it's had more amount of field work than any ICD classification so far. So that's something nice about ICD-11. Yeah, so ICD-11 has one major qualifier with anxiety symptoms. Okay. Both differ on mixed episodes. DSM wants certain criteria. We will not bother about that for today. The ICD-11 approach to assessment of severity of the current depressive episode is quite similar to DSM-5. Except that the number of depressive episodes, DSM will say more symptoms, it's severe. ICD-11 does not go for that. It depends on whether there is significant amount of impairment and functional impairment, and that's the way in which it's going to decide on severity. The similarities between ICD-11 and DSM-5, both have agreed on 5 out of 10 items as necessary. Both agree on the core features. And ICD-11 insists that the bereavement reaction needs to be separated from depressive episode. DSM-5 wouldn't bother about it. Say, whatever, you're depressed following so-and-so dying in your family, but you're not overcome the grief and it's going on for a long time, though it's depression. They don't want to make it separate. But by identifying prolonged grief disorder as something different, ICD-11, I think, is doing something better than DSM-5. Yeah, when I come to physiology, I mean this in a broader way compared to just a neural basis, like I said earlier, and this could refer to immunological, metabolic, and as well as CNS factors. Now, this again an important resource I want you all to note down. Brain and Neurosciences Advances, Volume 2. This is a very, it's like just 2017 or 18. It's an extremely useful article. I want, as postgraduates, you can definitely note it down. The Neuroscience of Depressive Disorders. A brief review of the past and some considerations for the future. And it actually says there's a major problem, one major problem when we come to understanding depression. We just need to overcome, okay, the strong reliance of researchers on crude diagnostic systems, primarily based on clinical symptomatology, and you know, regardless, and use the same label to apply to a whole lot of different types of sadness experiences in humanity. Now, it's something that they really focus on, and they say how we need to bring in neuroscience into understanding the different subtypes of depression, which hopefully can eventually tell us, you know, what kind of interventions can be thought of for different subtypes of depression. 3 major goals for the next decade, according to this article. Yes. All of you postgraduates interested who are working on depression for your thesis or wondering what to do after you finish your MD. If you want to focus on these 3 goals, there's lots going to happen around the world for the next 10 years. A neuroscientific model of brain processes and antidepressant response. Ecological process outside of the brain, like related to inflammation, immune reactivity, gut microbiome. Okay, so if you work on any of these things over the next 10 years or start focusing on these things, you're going to make a big name for yourself. So I request postgraduates to look at this and read that paper, read this particular paper that I put up earlier. Okay, if the organizers wish to share slides, I have absolutely no problem. I can hand over the slides to them, including the things that you're seeing now. So you don't have to really worry about noting things down. But I would really request you to try and get these 2 articles also. The one, Brain Behavior and Immunity, that's come in just hardly 6 months ago. And it's based on a 6-year follow-up of over 7,000 people from Netherlands. And it's a great study, Netherlands study of depression and anxiety. Okay, and there's a lot of good background information, biological information, and they followed this up for 6 years. And they say that Immunometabolic dysregulations may explain high depression, cardiometabolic disease comorbidity. Many of you know that in presence of depression, cardiac events tend to have a worse outcome. It's a very well-known, robust finding. Okay, and what they are saying is the immunological and metabolic dysregulation that are known to be associated with depression may be more common in people with where there is a cardiometabolic disease comorbidity, like hyperlipidemia, the whole metabolic syndrome. Okay, and only an atypical energy-related symptoms, okay, like some kind of fatigue or some kind of things related to, say, altered sleep rhythms or weight loss. Now, atypical energy-related symptoms were associated with more of the immunological abnormalities. So while we keep hearing about immunological abnormalities in depression, it does seem like it's probably refers to one subtype of depression when one comes to it from a neuroscientific point of view. And here's a little article, it's in fact a very long article, that our group has come up with, which focuses on culture and variations in depression with respect to adolescents in India. And it's something done with University of Miami. And this study is actually, I mean, the project is more or less coming to a close. You'll see quite a few papers coming from this, including a new scale on adolescent depression. And of course, there is a focus in the point of view of developing the scale. We have looked at how local contextual understanding of depression needs to go into any kind of depression measurements, and just picking up terms from certain other cultures and trying to measure severity of depression may be difficult. All of you familiar with these things. I mean, your youngsters would know a lot more about this than someone of my age. Lots of things all around depression. You can build a whole new ecosystem today. Social media, internet addiction, there's gaming, and there's a lot of issues around migration and COVID. Then there's a whole lot of things around nutrition, self-help, meditation, yoga. Okay, now when you say managing depression in the 21st century, okay, we're going to think about world of variety of information being available and huge number of web applications available to you. Within this context, how does one go about as a psychiatrist to manage depression? Now, from here you'll see some exciting slides very thankfully put together for me by the organizers. So these are catchy headlines you'll see in a lot of places. Right, and India leads in suicides, 18% rise in depression cases in last decade, 5 crore Indians suffer from depression. So you're going to keep seeing all this, so it kind of somehow makes everybody feel depression is that serious endemic issue that, you know, everybody, all types of doctors will be called upon to handle one way or the other. Okay, now all of you will agree, if you can now move from what is depression and how common it is, if you move on to the etiology, you will all agree there are genetic factors. We already talked about some neuroscientific, neuroscience and immunological metabolic factors. So there are all these kind of connected with biological factors / genetic factors, psychosocial adversities and childhood experiences. All of you need to know that childhood experiences are increasingly known to leave such a serious physiological mark on the brain that it kind of predisposes it to develop a depressive kind of ruminative thinking later on in life. Right, different brain areas. I'm going to flip through this. Many of these may be very familiar to you from various like this from Stahl's books. So many of you might be familiar with all these things. Okay, so so it's not just increase negative mood in depression, but also reduce positive mood. So anything you can do to work from both sides would be very beneficial. So like we said earlier, two major criteria in ICD-11, the loss of interest on one side and depressed mood. So the loss of interest, the reduced ability to experience pleasure. Nothing gives them pleasure. So this anhedonia has been studied in many disorders, including schizophrenia and autism and so on, but it's a core feature of major depressive disorder. And very importantly, when you find this extreme loss of interest in everything, and you need to really do some good, hard clinical work to elicit that. Just don't go by one single sentence saying it's not interested in anything. You need to ask, have you done this, have you done that, have you done that today, did you do this yesterday? And you find that they say that, no, we are trying so much, just doesn't come, not interested in this. This used to enjoy so much, is not at all coming close to even sitting there when something is being played on TV. So I think you need to, some hard work is needed to elicit it, but if you can find the reduced ability to experience pleasure and hedonia, it's a very, very key feature of depression, and it also predicts a response to antidepressants. So this depression is very common in variety of medical conditions, and so it can be cardiovascular, diabetes, Alzheimer's, coronary heart disease. So in many conditions, cancer, and it's very important to identify this and alleviate the suffering for these persons, because sometimes it may get put down to tiredness and lassitude and extreme inability to carry out activities and so on, but it may be depression masquerading that. And I think psychiatrists are in a particularly advantageous situation to pick up these by asking all the right questions. So it's a clinical burden, not just by itself, the severity of depression, risk for suicide, loss of function, loss of employment, and all these things, but it can cause morbidity and mortality in a whole range of medical conditions wherever depression is also comorbid. So, I mean, the treatment goals, you'll all agree, okay, is reduce signs, remove symptoms, restore role. It all sounds very right to do. But I wonder how many of you will actually think about each of this and say, now, have I tried to reduce some of their signs and saying, have I done something to make sure the relapse is not going to happen? I think the more conscious we are in following all these things, I think it will start helping us become better doctors. I'm sure you're all familiar with these kind of things, response to drug, and when the actual remission happens, and when the relapse happens before recovery, and after recovery there's a recurrence. These are used with respect to bipolar disorders. We can always talk about it with reference to depression too. Yeah. Virtually complete relief of symptoms. Okay, so here, the response is at least some significant reduction of symptoms. Then we have remission, which is significant, almost complete relief of symptoms. Then you've got relapse, the symptoms satisfying the full syndrome after the patient has responded or remitted. Then recovery is sustained remission over a period of time. They below written there at 6 months. And after that, again, when the symptoms come, we're talking about recurrence of a new episode where at least for 2 weeks you've got some symptoms there. Okay. So keep in mind all these things, that pharmacotherapy of depression depends upon preference of patients. As you grow older in the profession, you will learn to ask the patient if he's been treated before and what worked well for him. You'll be amazed at how quickly that will show response again if you're sure that it worked at the previous time. And safety, tolerability, you have to think about a lot of these things when you choose medicines, co-occurring medical conditions, definitely. And of course, sometimes pharmacological properties of medications. Whole lot of classes of antidepressants, undoubtedly, tricyclics, monoaminoxidase inhibitors, SSRIs, the NRIs, the SNRIs, and then this serotonin 2 antagonist and reuptake inhibitor, the trazodone and nefazodone. Then, of course, you got the NSAIDs like the mirtazapine, and of course, the dopamine noradrenaline reuptake inhibitor, the bupropion is a good example. But then there are some new ones. Okay, so you will never stop learning these things, postgraduates. I tell you, I mean, these classifications, they keep adding every 2 years, they add a new item into that. Yeah. Now, again, I must say that this is on the request of the organizers. They would like to focus on this. I'm not very sure why they want to focus on this. Maybe Mr. Veeraswamy and Gagan can talk about it later and tell us why they want us to focus on these things. But I think, yes. I'll let you speak again later when I finish, Mr. Gagan. What I want to say is, these are probably drugs they are hearing. I mean, maybe they themselves are going to be involved with, but they are hearing that these drugs are also new in the market, and they would like to very correctly, very smartly bring up the fact that a very good old drug from their own stable is actually doing so much better compared to many of these new drugs that are coming in the market. So the focus seems to be learn a little bit about the new drugs, but I'm telling you, one of the older drugs is working very well. Keep that in mind. That's some kind of a summary that I could glean from some of these slides. Keep that in mind. So there is an improved version of Milnacipran, they say. You'll see, read one more slide on that coming up. What he exited, I'm sure you all have tried your best to pronounce it properly. And then, of course, Vilazodone, which promised a lot. I'm wondering, I'm not sure how commonly it's being actually used today, because the special advantage it seemed to give, I'm not sure it's really sustained in the in the on the real field. Really, I'm not sure. But anyway, so the serotonin partial agonist reuptake inhibitor. Okay, the partial agonist bit was expected to reduce the the sexual side effects of SSRIs, and which causes particularly delayed ejaculation, and sometimes it can be so very disappointing for the partners. So they thought this can come about, okay, and it's kind of got approved. It's used, okay. Honestly, on the ground, from my colleagues, I find that it doesn't seem to deliver on what it's supposed to. Most importantly, side effects are one matter, but it also has to work effects. You see, it has to work as a good antidepressant. So there is some challenge around that. It doesn't work as well. And I'll later put up a slide. And for postgraduates, I really think you should know this. The Indian Psychiatric Society has done a fantastic job of getting some 10-15 centers around the country to just keep 1 week's write-up on, okay, here are all the depressed patients that you treated. You just give them the Montgomery Asperger Depression Rating Scale, MADRS. So they put down the scale for all these 20, 30, 40 patients you see in that week. You just put down and you write what is the antidepressant you prescribe for them. Okay, very simple survey, very nice results. We'll come to that later. I'll show you that. Yeah. So now this is one of the SNRIs that has come into the market, the levomilnacipran, and it has got a slightly higher affinity for working on the norepinephrine, because when you work on norepinephrine, there seems to be improvement in certain vegetative symptoms that are common to depression. So that's the advantage that levomilnacipran brings in. So vortioxetine, let me see about some time. Vortioxetine is one of the new multimodal antidepressants. Okay, and it's like we said, we already talked about it. It's an SSRI that binds to presynaptic serotonin reuptake. Again, just like any other SSRI for that matter. Okay, but it also got some subtle other effects, which kind of makes it because it's got this effect on, as it kind of works in, if you notice on the left side, it has got some kind of similarities in terms of not only the wide variety of serotonergic receptors, and that seems to offer some extra advantage to vortioxetine. Again, it's a drug that one has to learn to use, and not all patients with depression. Like, that's the whole point, If you club everybody is having similar, and you try to think that that same drug will work for everybody, it doesn't work. So it's kind of, clinical work is to try and find out what are those subgroups that respond to it. Vortioxetine, that data is still emerging, and we are not very sure to say exactly. Certainly, people with this profile are going to respond to vortioxetine. So watch this space. Let's see what we find over the next year or two. So you have 3 new drugs: vilazodone, vortioxetine, levomilnacipran. Okay, but let's look at why so many antidepressants in the market. There are nearly 30 plus antidepressants in the market in India today. Not all antidepressants have clear-cut efficacy in severe depression. Okay, and poor compliance and premature termination of treatment. It makes they probably just take for a couple of months, stop it, and then there's a relapse, and they feel terrible. Other thing, nothing is working. Then they continue to suffer for some more time. So this kind of compromising the chance of recovery. I mean, this is a definite challenge. So what one would think, okay, if it works fast, instead of waiting for 3-4 weeks, by which time they would get bored and stop the drug. Yeah, so maybe something with a fast onset of action, they'll quickly feel they're getting better and they'll hold on to it. Not many antidepressants. So many have promised, and they said, people have said this will work. Mirtazapine will work a little faster for you. I mean, it's really not been borne out. Even escitalopram is supposed to work much faster than other drugs. But we all know the onset. Minimum it takes 2 weeks to show clear response, see that the person is beginning to recover. Okay. You would have definitely seen all this, though it is clearly put down in Stephen's call as well. So rapid onset of action, intermediate half-life, broad spectrum efficacy. You can think of all the good characteristics you want in an ideal antidepressant. Postgraduate, probably one of the older drugs, meets many of these criteria. So you're going to be hearing about that soon. So just have a sense of all the kind of characteristics needed for an ideal antidepressant on the slide. And we'll see which drug probably meets majority of this. There we go. An old effective friend. And we look at sertraline, one of the few antidepressants endorsed by national survey. I told you this national survey, those are the 5 drugs that are written there, which one hands down compared to all the huge list of antidepressants that exist in the country. Okay, and it's surprising because when they do the survey, and for many cases people are sending the top, when they say top 4 or 5 are listed, almost every psychiatrist top 4 or 5 prescriptions seem to have this in that survey. I mean, it may not be because probably across around 70 to 80 psychiatrists. It's not like a massive number, but it was across the country, and it kind of really captured a sense of practice. Compared to many complicated studies, I feel this one survey gives such a good indicator about the type of practice in antidepressant therapy across the country. This came up, I think, 3-4 years ago. Probably a newer, updated version of the survey is due. But I think it's very important to remember that Sertraline, along with these 4 other friends, were probably the antidepressants which most psychiatrists in India would vouch for. We know about Sertraline. It has a higher in vitro potency, right? And it's an extremely good antidepressant. We all know that. All of you have read about that. And it's got, I think, one of the things which many of you might forget and may not be aware, that it's actually got a tiny wee bit of dopamine blockade, right? And at around close to 100 mg of Sertraline, it might actually have almost close to 1 milligram haloperidol blockade level up to 0.75 milligram of haloperidol blockade level. So this is an important this thing. It talks about reuptake inhibition on dopamine. What this slide does not talk about is that slight anti-dopaminergic action also which simultaneously it has, because that brings about some of the unusual effects, but also probably brings about some amount of calming effect, which is not often talked about. Of course, if it's only in small certain parts of the prefrontal cortex, this dopamine reuptake inhibition really succeeds to some extent. Okay, the funny thing about that is because many times the noradrenaline reuptake and the dopamine reuptake might happen through the same mechanisms in the prefrontal cortex. So sometimes you don't want pure dopamine reuptake inhibition. So those are all variations, but I'm sure you can read a lot about that in your favorite textbook of psychopharmacology. But it does help. Having a little more dopamine at the synapse in certain specific areas of mesocortical network definitely helps about in improving cognition. But actually, in the nigrostriatal pathway, the fact that dopamine sertraline actually has some anti-dopaminergic action makes it a very interesting drug. That is not highlighted in the slide, but you could go back and look at that. Yeah, I'm sure you know about this. Okay, but you can just have a quick look at it. Much higher doses can be used in major depression as well as obsessive compulsive disorder. And there's the pediatric dose that I'm often very keen on looking at. So 6 and 12 years, 25, 6-7-year-old getting sertraline for obsessive compulsive disorder can be a very complicated thing, but I would just say they kind of given the range, but keep in mind that you probably are going to be seeing very few of those cases, and the youngest ones with OCD that you're likely to see are more likely around 9-10 years and above. Okay, so in many conditions, you can use it at almost up to 200 mg per day, and sometimes at as low as. Right, an important article here, okay, a somewhat recent article, 2019, okay. Pharmacological interventions targeting anhedonia. I told you anhedonia is an important key feature of depression. It's highlighted in both ICD-11 and DSM-5. It's given pride of place, and it's one of the major targets for when you say I have treated somebody with depression, you should have made sure the anhedonia has come down. Okay. Now, when they say majority of currently available antidepressants do not show pronounced collinear improvements in anhedonia and other depressive symptoms. What they're trying to say is the same extent to which anhedonia is actually brought down, the other depressive symptoms, when you compare with that, maybe more of the other depressive symptoms come down, but anhedonia does not come down at the same level. So even though they might improve in sleep and appetite, and they may feel less sad and so on, getting that final interest back in actually doing things, it's not probably all antidepressants may not match the same level, but sertraline, according to this review, this is Progressive in Neuropsychopharmacological Biological Psychiatry 2019. It's a good, very high-dense journal, and I think you can all check that out. The review says sertraline has demonstrated beneficial action effects on measures of anhedonia as well as other depressive symptoms. So take that down and keep that in mind when you see the next depressed patient. I'll skip this slide. Lots of comparisons with different antidepressants, each time showing sertraline has done well. There could be studies which show opposite data too, but the collection that's put together with organizers suggests that sertraline definitely in some studies clearly show it's doing better than the other drugs. Okay. Yeah, the PANDA research program, it's something that you're all aware of. Okay, let's see what happens here. It can be prescribed for patients. One of the best things I find about SSRIs, and especially medications like sertraline and escitalopram, which have been so widely used, is that it takes care of anxiety and depression at the same time. Yeah, before we move on to the antidepressants in epilepsy, I want to say that because of the subtle dopaminergic antagonism, which starts becoming more and more prominent with higher dose of sertraline, what should be expecting that a patient on 200 mg of sertraline, after 6 months, they can show a small degree of apathy. It's not put down here, but since it's the class for postgraduates, I would like you all to recognize this. Sometimes these apathy can be quite significant, and you may actually find that using a norepinephrine dopamine reuptake inhibitor like bupropion over and above sertraline. So somebody is on sertraline 200, showing a lot of apathy. They seem to have improved in many ways, but after some time you find that they seem to be, just not responding to the surroundings with the same zing that they may have done earlier. Okay, it's not only limited to sertraline, it's seen in a variety of SSRIs, but it's something to keep in mind. And sometimes if you feel otherwise the antidepressant effect has been good and you don't want to lose that by removing the drug, 150 mg of bupropion can actually significantly make a difference to these patients. So something to keep in mind when you're using sertraline. Antidepressants in epilepsy. People with epilepsy frequently have comorbid mood and anxiety disorders. That goes without saying. And depression is the major psychiatric comorbidities having a negative impact on persons with epilepsy. Clinicians applying first line of depression treatment in patients in epilepsy should always keep in mind that TCAs, tricyclic antidepressants, and some of the NASA like mirtazapine and maybe and definitely bupropion. These are all drugs which reduce the threshold for seizures and cannot be used. In fact, bupropion is totally to be avoided in presence of epilepsy. But sertraline, escitalopram definitely share a good comfort profile in patients with epilepsy. Fluoxetine also, but the problem with fluoxetine, it might start amongst all the SSRIs have this annoying ability to raise the levels of other concomitantly administered drugs because of blocking the cytochrome 450 oxidase system. But sertraline does less of that, thankfully. Okay. While fluoxetine more likely to bump up all other drugs that are being given simultaneously. So sertraline definitely, I would definitely go with this, that it definitely is a very safe antidepressant in presence of epilepsy. We'll just skip this and move on. So there you go. Some work that suggests that sertraline can do quite well, or probably better than CBT, right? Especially in terms of remission rates. Okay, but it hides the fact that CBT might have brought about certain changes in the individual, which will last even after the treatment is completed. But when sertraline goes away, sometimes that effect may not last. You may need to continue sertraline to continue having that effect. Keep that in mind. So it's not to say CBT is in any way inferior. It just says that CBT produces such good improvement. Come on, sertraline also does equally or maybe even better than that. That's definitely something worth keeping in mind. I want you to focus on this. This is about treating depression in presence of diabetes. Now, depression and diabetes, there's a huge amount of overlap, and it kind of each one worsens the other. And diabetes is one of the commonest disorders that any physician, any type of medical practitioner, anywhere in the world would be, whatever practice or whatever specialty it is, will see patients with diabetes. And depression can be something lurking there in presence of diabetes all the time, and it kind of tends to worsen each other So one has to look for it, and invariably, if you've been thoughtful and you've identified that, you come to a point where you have to treat it. And definitely, certainly, it's one of the better medications in presence of diabetes. So there has been nice, good studies. I mean, I don't think you should worry about the details. All it says is it's come in Indian Journal of Endocrinology and Metabolism. Yeah, Indian Journal of Endocrinology and Metabolism, 2019 May. So it's from our own country. There's an open label randomized control trial looking at sertraline as an add-on therapy in type 2 diabetes mellitus. I mean, it says significantly improved depression scores in patients with type 2 diabetes mellitus. It's very important to recognize. Definitely it's a nice study, and it's good to know that sertraline works and you can use sertraline. It's a safe option in diabetes. But I would really emphasize the fact that you need to look for depression and treat that in diabetes. But there is a catch. This is one of our papers from St. John's. We were actually trying to run MSc psychiatric nurse led, but also, she was the front-ending person, and one of our consultants was supporting her, sitting inside a diabetes clinic where hundreds of patients would come every day, and trying to assess their distress and depression and so on. Okay, so we found that there is something called diabetes-related distress. A lot of patients, more than 20% to have this. They look quite similar to the depressed patients with diabetes. They look quite similar, but in them, it's like the health anxiety kind of condition, which is somewhat different from generalized anxiety. These are people who are intensely troubled by the fact of having diabetes, the routes they have to follow, the challenges, and the constant worry about what it can do to them. So, diabetic-related distress, which we separately measured using an independent scale, is those patients. There are quite a large chunk of patients with diabetes who have this, might initially look like depression, but actually may not be really depressed. Like I began the whole chapter by saying how they can be, it may just look like similar symptoms, but the origins may be quite different. So using the same term and think everything is the same is a very poor. In 21st century, one of the first things to remember is diagnostic systems have tried to make this reasoning, but let's not lump all depressions to be the same, and as if all depressions will respond to the same kind of treatment, and you use the same set of medication for all these patients. It's not a very good approach. So you should look at certain specific features to this, and diabetes-related distress, which can be actually helped through very good, not only education, but also certain practical brief counseling skills. And that is what we actually tested out in this article, which came in IJPM 1.5 years ago. Danya, my colleague, is the lead author of this. And it definitely, psychological intervention delivered by nurse was found to significantly elevate, and it actually led to improvement in their diabetic control as well. So keep that in mind. So not all sadness in presence of diabetes might need antidepressants, but diabetes is one condition where a lot of people have significant depression. You need to identify it, separate it from diabetes-related distress, go ahead and treat it. It will probably improve their quality of life. Same thing with heart diseases. SAD heart study is a very well-known study. I'm sure you all have heard about it. The greatest thing in this study is to remember that within a week of having myocardial infarction, sertraline is found to be very safe and treating the depression in this group. And we all know that depression soon after acute myocardial infarction worsens the course of the ischemic heart disease significantly. So sertraline was doing something good here, removing the impact of depression. So we'll skip through that. It's sertraline again very safe in pregnancy and lactation. This again something to keep in mind. So broad spectrum antidepressant, it's one of the most favorable balance between benefits and acceptability, safe in pregnancy and lactation, low risk suicidal tendency than other antidepressants. Means you need to really take quite a few sertraline tablets before it becomes fatal to you. So it's a good drug. Sertraline beats most of the new drugs in the market today. Sertraline is one of the 5 drugs that the Indian Psychiatric Society survey has endorsed as the real good antidepressants that people would like to use. So there you go. Competition between old and new drugs will continue. And it reminds me, some years ago when I was a postgraduate, there's a lot of debates about tricyclic antidepressants versus MAO inhibitors. And we all believed that time, because MAO inhibitors were not available in India at that time. You think once that comes, we would all be extremely good at treating depression. Little did we know that within few years of our qualification, a whole lot of serotonergic drugs came. and more postgraduates today will know about SSRIs, the DCAs, I'm sure. So they will have the TCA versus SSRIs debate, and like just now we saw, there are debates between SSRIs and the newer drugs that are coming into the market. I think it's very important to continue systematic surveys like Indian Psychiatric Society has done of antidepressant practices around the country and develop a clinical perspective, because there are 30 odd antidepressants available today, and you need to get your head around half of a dozen which you learn very well. You become very adept at understanding its dose, titration, side effects, and you find a drug like sertraline really takes the cake, because it could probably help a vast majority of depressed patients that you might see in a psychiatric clinic. Newer drugs coming. This was actually, I saw this on the day that I was supposed to present last Saturday when it was supposed to come through. Okay, and I found the news that pharma sector to grow 3 times in the next decade. Okay, so that's a big deal. Okay, so this is, you're going to be hearing a lot of growth of pharma industry in the coming decade. A lot of new avenues being opened up for that, and antidepressants are going to be one of the biggest groups that the pharma sector is going to be targeting. Yes, before I come to this, I don't know how much time we have left. I think we have, officially speaking, we just have 3 minutes left. We started a few minutes late. We can probably take another 10-15 minutes if the organizers are okay with it. And I particularly, when I open up the next slide, and that's my last slide, I think, I really want the postgraduates to join and have a discussion. Because so far what I have said, in the 21st century, these are the criteria, these are the conceptualizations of depression, and these are the wide variety of drugs available to you, and there are these competitions between antidepressants. So that's the context you find with. That's what you're going to be seeing there out in front of you to apply with your patients. But is this enough information, knowing how to diagnose depression and how to use, what are the antidepressants available? Is that going to be adequate in 21st century? Or what are all the other different kinds of things that will be impacting antidepressant practice in the 21st century? That's something for you all to think about. And I want you all to participate in this. Please discuss, stop at any point. Don't let me see that's lost. So I will have to. Yeah. So depression is more recognized in urban Indian settings and definitely on the social media. You all agree with me on that? So, I'm not saying it's not found in rural settings, but definitely it's more recognized in urban Indian settings. And very big issue on social media. There is a convergent view growing on the diagnosis of depression. ICD-11 and DSM-5 are coming pretty close to each other in how they're thinking through depression, though there are some important differences. Of course, keep in mind that prolonged grief reaction, according to ICD-11, is independent of a depression diagnosis. So if you find that, if they're having some neurovegetative symptoms, you can always give them some antidepressants, but the key thing is make sure they get good psychotherapy. Now, when we talk about multiple new etiologies, we are talking about the immunological etiology and the metabolic etiology. It's something to keep in mind. These are all going to be on conceptualized depression in the 21st century. Numerous challenges post-pandemic work, something the world that we're going to be talking about. So how the need to stay at home has, what kind of interpersonal issues it has created, the social distancing, what kind of interpersonal issues it has created, and how these things impact on one's mood. All of it, something missing in my list here, I think I should have said this here. There is a definite recognition that in 2020, there was a spike in suicides all over the country. In fact, severe mental illness patients seem to have done much better with schizophrenia and bipolar disorder, but patients with depression, anxiety, staying in their house, facing up to interpersonal issues, many of them have actually resorted to suicide. So all these issues are going to play on your minds when you think about practicing depression in the 21st century. Of course, numerous medication options, and you will hear highly popularized new methods of yoga and meditation coming up, and then apps and self-help. In fact, major pharmaceutical industries in the West, like Janssen, Pfizer, and all, are launching apps that are supposed to be. They're actually launching it with the same vigor that they're launching antidepressants. They are launching apps, self-help apps, as the way to treat your depression. So they kind of create an app which will take you through certain steps of CBT or interpersonal therapies and so on. And they actually are supposed to in a very virtual world help you deal with depression. So these are all the things that are going to be available to people as one starts thinking about treating depression in the 21st century. And is there a low mood pandemic? I mean, everybody now talks about being depressed and stressed. Low mood pandemic itself. And of course, a whole lot of new vulnerable populations constantly keep getting updated, newer and newer types of vulnerable populations. So my last sentence here for today's presentation is, how do we position the shrink in the midst of an expanding view of depression in the 21st century? It's something for you all to think about, postgraduates. I now look forward to some interesting comments from your side. Okay, so open now for discussion. Or if the organizers have something to say, quite happy to hear them.
Audience, please ask your questions. Sir, is there any query? Please ask. Please sort the questions in the chat box also.
Is there? Are there? I'll just stop sharing. Okay, is that okay? So I can come out.
Yeah, yes, doctor. Yes, doctor. Yeah. Yes, sir.
Okay. So there we go. There's some things in the chat box. Is it? Somebody started saying that there was a patient, Panchami Pinku. You started saying something. I'm sorry. It says to me privately. Maybe. Do you want to discuss something, Panchami? Feel free. Are you around?
No, sir.
Yeah. I'm not sure if I went very fast. I just had to cover a lot of slides.
Yes, sir. No problem, sir.
Yeah. So Pancham is sharing about a 12-year-old child with history of idiopathic hematemesis. So they don't know why the patient is vomiting blood. The young child is bringing out blood, and then the diagnosis with severe depression. Okay, what would be the best treatment option? Yeah, it's an interesting question. Okay, and a few things to keep in mind. The adolescent or pre-adolescent kind of depressions very often may not be like the adult kind of depression. Okay, and their tendency to have more separation anxiety symptoms, and their tendency to have poor concentration and being little impulsive and have a lot of swings in mood. These kind of features are more likely to be present. So when you say they were diagnosed as severe depression, I'm not sure what exactly you mean by that. But in the younger children, you tend to see a mixture of anxiety and cognitive factors, neurocognitive factors, more than pure loss of interest of like anhedonia of the adult depression variety. Okay. Now, but if you're convinced the depression is there indeed present in this child. I mean, it looks like it says history of idiopathic hematemesis. I don't know which it means the patient was actually having hematemesis, or there was a suspicion that the patient might actually be, kind of bringing up blood in some way to kind of get help for herself or himself. I'm not sure what is meant by that. If indeed there is significant hematemesis going on, a loss of blood, anemia itself can kind of mimic some kind of neurovegetative symptoms of depression, extreme fatigue and feeling apathetic because they're not able to actively engage with their peers and so on. So it's good to first make sure that indeed the childhood depression equivalents in terms of poor concentration, extreme separation anxiety, miserableness, not wanting to play, being with friends and so on, many of these things are clearly elicited in this child. If that is done and you're sure about depression being present, and especially if there are significant biological disturbances in terms of sleep, and the child is actually doing poorly, in this case, if the child is having weight loss, you will not know it's because of the medical condition or depression. But if you suspect that after improving the medical condition, bleeding has stopped, but still the child is not gaining weight, now it's all related to depression. So if you have this kind of significant features around the child, then I think an antidepressant use is perfectly justified in this child. The medicines, antidepressants which have got good evidence in younger age group, there you go again. Certainly there has been some very good trials in young children between 12 and 16 years of age. So it can definitely be a good medication that you can think of in this child. But fluoxetine is probably one of the safest antidepressant in children, because the fancy notion that some antidepressants induce suicide intent, which is a highly controversial entity and many people don't believe it. But fluoxetine at least doesn't have that stigma at all. People have never talked about fluoxetine inducing suicide intent. So it's a pretty safe drug to be tried in children and young adolescents. So if you want to use that, you can, thank you for more details that you've been giving there, Panchami. So certainly if you get significant features of depression, you should not hesitate using fluoxetine or sertraline in this child. You will start with fluoxetine 10 milligrams or you will start with 25 milligrams. Now the thing is, hematemesis, there may be a catch. You may say it's a medical issue. And SSRIs, there has been a small doubt about whether they increase the risk for bleeding. So that can be a catch issue there. And sometimes, if you are asked the same question in the exam, the examiner might catch you and tell you, no, you mean to say you're going to give a drug that can actually worsen bleeding? I don't think I would get caught up with too much of that. The risk of bleeding from SSRIs is extremely small. And in this case, you are saying we don't know why the hematemesis is happening, but if all the bleeding, clotting parameters and all have been fine, okay, and you can always make sure that medicines are taken along with breakfast and make sure that gastritis and other complaints can be kept down. So these are all things you're going to be especially cautious because this child has got hematemesis. You don't want to worsen that by giving a drug that can cause more gastritis. But if you can make sure that it's given soon after breakfast and monitored for a few days to see that there is no worsening of hematemesis, so you can be very sure that this child will start responding from day 12, day 15 onwards, and you will start finding that a whole lot of positive cycle of events starts. Yeah. So you can argue why should then we not try TCS at all if there's risk for bleeding. There's nothing wrong with it. But when talk about the evidence available for depression in this age group, the best evidence that exists is for fluoxetine and sertraline, and it's something to keep in mind. It's not that you should not try the other medications, but these two drugs are better evidence. So that's regarding this case. I saw some other questions also.
Yes, sir.
There's another question. Yeah, sorry.
Yeah, Dr. Shashi Gupta is asking the role of stimulant in cancer patients, sir.
Yeah. See, the thing is, again, like I said, what are we looking at? Are we looking at depression? Are we looking at apathy? Now, if you look at apathy, is actually indifference to emotional indifference to surroundings with a reduced drive for doing anything. Okay, so it's like a motivation thing as well as an emotional indifference to surroundings. So there are two components to apathy. Now, apathy is not at all uncommon in patients with cancer, especially with the wider spread of cancer. And in such patients, you probably don't want to mistake that for depression per se. So you'll have to be very careful what you're looking at. So if you find that indeed so keep that in mind that the chances of apathy is higher in these patients. So, and like I said, certain higher doses of antidepressants, if tried, can actually induce a state of apathy in some of these patients. So you're going to keep that in mind. Now, the antidepressants which has got the highest ability to reduce apathy, one is bupropion. Bupropion, because of its ability to have a significant dopamine reuptake inhibition, is known to actually reduce apathy. Like I already said, it can be used to reduce sertraline-induced apathy also. So apathy, if is what you're looking at in this group, and it can be quite common in cancer patients with multiple spread of multiple metastasis. You may want to, if you want to think of a drug, you're better off using something like bupropion. But if they have neural metastasis or carry other risk factors for seizures, then it may not be a very great choice of medicine. You will not be allowed to use that medication. Okay. So then, again, you have to ask yourself, is there depression or is there only apathy? If there is more apathy than depression, stimulants will play a good role. It's a good question that you asked there. So stimulants can do a good job if there is more apathy than depression. But if there is significant depression like hopelessness, helplessness, worthlessness, feeling suicidal, they don't want to live anymore. And many cancer patients might feel this persistently for long periods of time. Then stimulants alone may not do the trick. Then you may need to use an antidepressant, and if supposing the reduction in apathy is not significant, then you may want to add stimulants. But stimulants alone may not be adequate with the full-blown depressive symptomatology in this group. Are there any other questions that I can see? Yeah, so those are the two questions. They were listed in the chat box, but we can certainly have other questions discussed. But apart from that, what I would like to know from you all is, your views on 21st century and how to treat depression. That's the topic, title of today's talk. how they'll come and say that they're very upset because they are not getting enough upvotes on their against their name on Instagram or Facebook or something, and they're extremely depressed. And their entire world was around multiple contacts they had virtually, and they're not able to connect with people. Now, are you going to help? Sure, Shashi, I'll come to the ketamine issue. Yeah, are you going to be talking about helping them make real life relationships and get on to lead a more productive, active life? Would you put more energy on that, or would you feel that the sadness coming from losing out on number of Facebook friends would be enough to only warrant antidepressants? I mean, you're going to be faced with these kind of questions in the coming years, and it's good to reflect on that. So that can be an issue. Are you going to come and say patients will refuse to try antidepressants, saying they somehow don't believe in medications and they would like to do it through yoga and medication? Okay, how are you going to conduct a clinical negotiation with the patients? Because you cannot antagonize them because in Indian kind of setting where there's no community outreach activities for most clinicians, if they don't come, you can't go and reach them again, right? And it's also very peculiar. Your secretary can't keep on calling them and asking them to come, because when they come, you're going to charge them, right? Now, it's very difficult to do that ethically and very comfortably. You can't keep calling patients to come, because when they come, you're going to charge them. It's a very difficult ethical scenario. So your best bet is how to make patients feel comfortable to come back to you. So the clinical negotiation you're going to have, which may not, now they are refusing to take antidepressants. So does it end there? Or can you actually engage them with the sense that you're actually wanting to understand them, you actually want to help them? How are you going to conduct this negotiation and see that, okay, you're going to be practicing yoga, we'd like to keep in touch, I would like to find out what is improving, what is not improving. And if we find that after so many weeks of using yoga, some bits are improved, but some things are persisting, we can renegotiate and look at it and see if any other kind of help that we can offer is going to be helpful to you. How do we actually conduct these kind of negotiations? Because you're going to be facing these kind of issues more and more. You're going to face issues in terms of people with diabetes, a huge thing. Almost 20-30% of patients beyond 50 years of age would be having diabetes, and nearly half of them will express a lot of significant sadness, distress, and so on. So how are you going to distinguish those with diabetic-related distress versus use of antidepressants in these patients? And how will you monitor the side effects of antidepressants, keeping in mind the needs from the diabetes point of view as well? So there should be no weight gain, there should be no drop in appetite, so then they end up eating less and they go into hypoglycemic episodes. So you're going to be constantly thinking about these kind of complex presentations are going to increase. Complex presentations due to medical comorbidity, complex presentations due to virtual lives they may be leading, complex presentations due to wanting to have their own different lifestyles in terms of different choices, different people, because they have opportunities to choose from a wide menu of lifestyles. So people come with that amidst their different lifestyles and language to identify features of depression and see where you can actually make a difference. And even if you find that they're unwilling to use the treatments that you offer, how do you engage them and carry them with you so that you can be of some support and help to them? These are all going to be interesting challenges of treating depression. Of course, there's a big challenge of 21, 30, 35 antidepressants available, and how do you make the right choice? I want to hear something from people here on that. So yeah, there is, before I can talk about ketamine, I would like to mention our experience with 2 such patients where we use ketamine. But before that, it would be very interesting if any one of you here will talk to me about what you see as an interesting 21st century challenge in treating depression. I don't think anybody's putting up your hand. So, yeah. Okay, we'll let that pass. Yeah. I think there's a big focus on live with you, Shashi. I mean, I think it's a growing field. We have had some experience with that because, like we said, we sent the MSc psychiatric nurse with training to assess depression and look for help in the diabetes clinic. That's liaison psychiatry for you, isn't it? So you actually sit there, patients are coming day in and day out, and there's somebody suddenly asking them more questions. Are you feeling sad and hopeless in the last 1 week or something? And suddenly patients are talking to you and seeking help. And we have had advantages of actually providing alcohol brief intervention services in the gastroenterology wards. It's been running for 5 years now, and nurses do a fantastic job of this. And they screen patients who look different from the usual ones there, and they can screen them for depression also and come up look for help. We have had great success in monitoring suicide patients, not only around the time they get admitted for acute care in medical wards, but also for up to 6 months in the community. We keep telephoning, calling them up and discussing issues with them. And you find out that some patients who did not seem, because it seemed like an entirely situation related condition when they are admitted, and you did not really think of treating them with antidepressants. But over the next few weeks, if you're in touch with them or you got a service where a nurse can reach out to them, you might actually find that you can keep screening them, and some of them might qualify for depression. You can call them back and treat them. So many times, liaison psychiatry gives you tremendous opportunities to identify new patients. Liaison psychiatry in adolescent settings, in cancer settings, it gives you tremendous opportunity to, because unless there's something looking dramatically different from the rest of their patients, oncologists and cardiologists may not pick out these patients as needing depression. And also you must learn to understand that they have a particular view about how patients will react to them when they go and see. Every patient with, every cardiologist will say, more or less, I expect people with myocardial infarction to react to me like this. But this patient is reacting in a funny, different sort of way, and I'm not able to understand it. So let's get a psychiatric opinion. Now, how do they think? What are the signs they pick up which makes them feel they are different? And then using those signs with your colleague who is the cardiologist, then to educate him about which of them may be depressed and not, and how to pick out depressed cases. Now, this kind of liaison psychiatry will find you patients who will be extremely keen on taking good care, who will not fight with you about choice of treatments, but who will greatly benefit because they didn't even expect that to happen when they came into that medical setting. So I think liaison psychiatry is really an important way to go for psychiatrists, and you're going to find a whole lot of patients with depression there whom you can treat, who will actually benefit from it, and who will actually demonstrate gratitude to you in ways that a lot of everyday depressive patients that you see may not do it also, because they're somewhat different. They're fairly healthy people, land up in a medical issue, they're also having depression. Their ways of reacting to it and reacting to the physicians are very different. So liaison psychiatry is the way to go. Thanks for that, Shashi. Yeah, ketamine, we have had experience of using that only in 2 patients. Like, I mean, I'm sure I would refer you to the book. I mean, I must say that I would have depended on my senior assistants to figure out the dose and all that. But definitely, it's a drug which reduces suicide intent right there in front of your eyes. If you have really identified a patient with significant suicide intent, you will find them, if you start the infusion